on. There's no public here that I see, so we won't worry about public comment tonight. Approval of consent agenda items. Are there any questions on that?
I move that we approve the consent agenda items as presented.
Second.
Those in favor?
Aye.
Aye. Thank you.
Chuck, did we get the check, February check on the phone to fill out?
Yes, I've got you down for the 8th.
Who's on the 22nd?
Gerald.
Aye.
You have a month off now, Mr. Bond.
Yes, I do.
Trying to
One
get
of those
John,
rare months.
John a break and then spend his time writing limerick.
Good looks.
Call the papers.
November 2016 Lake Health District Financial Report. That's a big title, Cheryl. Go ahead.
You should go out there and take the last picture tomorrow.
Yeah, I know.
I actually have been thinking about that.
I was hoping Leslie would do that because she's good at, getting those, so
I
she
should
can
have
get to
taken of you.
them, or get to them or whatever. Okay, so why is it off the thing all of a sudden? That's sort of weird. There. Okay, so November, we had 330 patients in the hospital. If you look back, you'll see that November is, for whatever reason, a typically slower month for the hospital, but this month was really, really slow. Year over year, we've had a decline of almost 13% of patients in the hospital. This number increased by 5% from last month, so that's how big of an impact November had on us. Ancillary services is not really nearly as bad. We do see a slight decline in lab and radiology. It's driven by a decline in hospital patients. Big increase in rehab patients, 17%, that's awesome. Home health, we know historically goes up and down, so that's not really very noteworthy. And a 7% increase for the patients that we're seeing in the clinics, which does help to make up for that reduction in patient counts. Our monthly revenue is right here on this green bar. The revenue for the month was $2.3 million. Our average so far this year is 2.5, so that is, rather significant decline in revenue following the decline in patient counts, not a surprise. Our collections for accounts receivable were terrible. They were $1.3 million. Our average in 2014 was more than that. Our average for this year is 1.6 million now. So it was really bad. And that, of course, drove our, I do move backwards. So our days in the ER is up to 86. It was at 81 the last 2 months, and now it's up to 86 again. And this, of course, has a lot to do with the lack of cash receipts. We are, in fact, starting a revenue cycle review next Tuesday. They'll be here Tuesday, Wednesday, and Thursday. And I expect that we'll learn a whole lot about how we can make this better.
Who comes in to do that, Cheryl?
A company called TrueBridge, which is a company that's under Evident and CPSI. I'm not quite sure how they're all connected, but it's affiliated with the company that we have our software with.
So CPSI, which is now called Evident, the software is called CPSI. Evident formed a company called TrueBridge to provide consulting services to all the hospitals that they sell software to. Because a lot of the hospitals had trouble with their billing, had trouble with all different kinds of things related to the running of the business. And so TrueBridge was formed to provide that consulting service. And because TrueBridge has a very active revenue cycle management consulting portion of their business, we know our software, they're able to look around and find some of the issues that we might be missing out on. That's why we engage them.
And as we know, the financials are really driven by, you know, our patient care and our patient load. Do we see that, you know, it's trending downward a little bit? Do we see a reason for that, or is there, like in December, is it starting to trend back up?
Teresa,
Don't be asking me.
We had a good December, and we were having a completely insane January at this point. With record patient counts.
Okay.
So I
So
think November was a weird anomaly.
It was a hiccup.
Yeah, I am, it was an odd.
Because that's what really drives all the numbers.
Yeah, it
But
is.
we were down in October also.
We were, we've been
And we were down a little bit, weren't we, in September? I don't know, about 3
Yes,
months that we've
yes,
been
but
down a
then you
little
have to
bit.
question, there
Right.
certainly is a huge, you know, the government, in the industry in general, there's a reduction in the days of inpatients and inpatient surgeries, and the ED is going down, but that's because we've got clinic, we got walk-in, we got, you know, the increases that we see in clinics are coming out of people who would rather go to the clinic than the emergency room, which of course is a way better place to go. It's cheaper, it's faster, it's better, see the same doctor, oh, good, right? So, anyway, but yeah, definitely, generally is a decline in those hospital patients. And yes, that drives our revenue cycle, but it doesn't really have anything to do with why is it taking us 86 days to collect our money.
Yeah.
You know, that's kind of, no matter how many
Okay,
days.
that's where the consulting comes in as well.
Yeah, we need to build, we definitely need to do that better. All right, so days cash on hand is here now at 133, and of course it was really low. And it has bounced up to 133. Last year it ended with an average of 152, so it still seems low. But keep in mind, given the low collections from last month, I mean, that money's probably gonna bounce back. We'll have a good month this month or next month, so we'll have that. And the other thing that's really still impacting that is we are paying for the construction costs up front. So I'm gonna do another bond draw, I think, tomorrow or Monday, and we were working on putting it together so we can sign the paperwork. But, you know, that's probably another $1.5 million that we paid out, so that we'll get back. And that'll keep this number a little bit artificially low.
Keep in mind that when we do a bond draw, we have not borrowed the money. We have the ability to request that money. And we, rather than do it just monthly, because every time that we ask for money from the bank, which we've been authorized to do, we have to get a legal opinion on that bond draw. So rather than incur a lot of expense of getting a legal opinion, every single time we ask for the cash, we're managing that process.
And they have to send something out there to inspect it.
Always, it has to be
Yeah.
inspected, that's right.
Okay, so our profit and loss for the hospital for November, this is the month of November. This is our year-to-date, and so you say to yourself, wow, so revenue's over by $380,000. It doesn't really make sense, but the reason why revenue is over budget by $380,000 is because $550,000 has been recorded for the wellness center. And also this month, we recorded $210,000 reduction in our contractual expense because the cost report was completed and that's what Medicare owes us. So if you took those things out of the equation, we would be under budget by $380,000 instead of. Our expenses, so salaries and materials and services, those two are collectively over by $770,000. 430 of that is the wellness center. And then we've got several departments, surgical lab, PT, that are each over by about $55,000, which has mostly to do with contract labor, which just is so expensive. And then our clinics are over budget by $182,000. So, but we've hired providers, and we've got, we did have that one contract, FMP, and that was very expensive, and that was not in the budget, so.
Keep in mind that we did not put in the budget for having mental health and wellness center. So you'll always see this variance from what the budget is, because that was not part of the original approved budget from June.
And your cost report adjustment, was that for the clinic too?
Yes. Yeah, the clinic is part of the hospital system. So, Lakeview Gardens has a separate cost report, and Andersonville has a separate cost report. Benefits are under budget by $81,000, and that's because we did anticipate an increase in our health insurance cost. But unfortunately, that insurance came through this month, and it's gonna be $22,000 a month, which is twice what I budgeted for. So by the end of this year, this under budget of $80,000 is gonna become an over budget of about $74,000. But we've had such good luck with health benefits, it's hard to fill. Like, that's not probably a fair number. Let's see, so for the month then, we lost $139,000. For the year, we've lost $189,000. And we had budgeted to be a profit of $100,000. Our balance sheet, the only significant changes that we're seeing on our balance sheet month to month is that as we are recording construction costs, our assets increase because that goes straight into construction in progress asset account, which causes our cash to go down. But then on the other hand, our cash has gone up because we did book the almost $3 million that we borrowed against that bond. So other than that, we really don't see as serious changes to our balance sheet. Okay. All right, and then last here is Wellness Center. And I am working on a budget. I really don't have a budget complete. I have spent really good time with Trey Swanzer and also with Francine talking about how things work, and I feel like I've come a long way to understanding it. I would tell you right now that I don't expect these expenses to change very much from where they are. The only thing that's really gonna change is that we're gonna continue to hire people. And based on conversations with our auditors and what I've learned about Wellness Center, my expectation is that as we hire people, obviously wages and benefits is gonna go up and expenses might go up modestly, but revenue might not necessarily go up. So we will have to start building a practice for commercial payers. So non-Medicaid patients, non-Gobi patients that we would expect to start seeking mental health services. What we know, yes?
What's the big change in revenue between October and November?
And I explained this last month, and why did we have an extra? Because I took, which is related to what else I'm gonna say here, is that because what we're going to do is to take out of the fund balance, we got the $1.3 million. That, a lot of that money was slated for new hires, for additional staff, and it was, and we took money out of the fund balance, which we basically put in, you know, it's like retained earnings, it's our net balance at the bottom of the balance sheet. They gave us $1.3 million, we put it in there. What we're gonna do is very selectively and carefully, we'll take, when we spent an extra $100,000 on IT infrastructure and on building, we fixed up the building, so we took it out of fund balance and we reported it as revenue, so that we wouldn't be showing a big loss on the Lake Health District's books that was caused by Wellness Center. So if we, and this of course is all done at the advice of our auditors, our accountants.
So roughly how much money is left in the fund balance?
Well, I mean, we got 1.3 and we've taken 100,000 out. I mean,
Well, that's all you've taken out.
yeah, so, you know, I think what we're gonna try to aim to do is to, we need to build this business, we need to hire people, and we need to start seeing some commercial payers and then kind of assess how it's going. But for the most part, it's gonna be a break-even business, because we're gonna kind of invest their money in growing that business and not.
Right. Well, state law says.
Yeah, it's gotta be spent on that, yeah.
Mental health.
And in fact, they had,
Dr. Graham, can I ask a question? How do you see this impacting your end of things if we're able to provide better mental health care to some of the patients you're seeing now? Is that going to take some pressure off of you?
No. They're still gonna come to us first. They're not gonna seek it on their own most of the time. And they're gonna be referred, I would assume. And commercial payers are not very prevalent out there that are gonna seek mental health services in my book. It's gonna be your welfare patients.
Do you think it's because it's a stigma?
Yeah, here in Lakeview it is, because most of commercial third-party payers are going to go to a local mental health service in a community our size because everybody knows everybody. So most of your third-party people who want to go out or want to seek services want to seek it out of town. So it is a stigma, yes, and it's a problem. And when you try to convince them to stay in town, they're like, well, I know that person and I'm not comfortable with them knowing what's going on in my, you know, it's that kind of mentality. So, yeah, so the people in that regards that are gonna fund that extra are probably going to wanna go away. Unless they're new to the community and they don't know anybody.
but we're also hoping if we integrate a mental health clinic with a physical health clinic, people aren't gonna know who you're in the waiting room to see.
Exactly, so I'm trying to figure out how we can overcome that barrier,
Mhm.
because there's gotta be a way
Right.
to get around it, but it'll take some time.
Well,
It's tough.
Yeah.
It'll take some time.
Yeah.
I was just curious as to your opinion on that.
That's a tough one. That's a tough one to make up, honestly. I mean, I don't know the mental health numbers very well, but.
And I would think that we should anticipate grant on that, so I'm not sure how that's gonna come out really, but there is money out there. So we're working on that.
But Cheryl, you made a comment just a few minutes ago that you think that this is going to, over time, just be pretty much a break-even operation.
I think that it's gonna definitely be that for the next 12 months or so as we hire people as well, and we can use the fund balance to pay for additional wages if they're not generating enough revenue to cover it.
And if I can chime in, because more than likely, we're going to be getting our younger LCSWs coming out of college, that, you know, they'll need training and develop that clientele, so it's not gonna be bringing in seasoned professionals that can just hit the ground running. That's my view as a recruiter, but
But you made a comment that you thought that adding additional staffing is not going to increase revenue, that's strange.
Well, because you've got Gobi, it's based on the number of patients you see, and we know that we're not providing that those
But
people.
won't we see more patients though, if we have more staff?
Yeah, but I don't think that we're fulfilling the contract now. We're not providing all the service that we're contractually obligated to Gobi to provide, because we don't have enough people to do it.
like the drug and alcohol counselors.
But you're saying we're getting paid for it even though we're not providing it?
Right. That's right.
But
And
I-
if we provide more health, more care, we're not gonna get paid more. So we've got to be, you know, careful as we grow this, that, and become very efficient.
Yeah, we do have the reserves. so-
A lot of money, yeah. You're gonna have to use the reserve to do that.
I felt like the information that we got was when we grow this, that we would just get a better reimbursement from the state for the patients that we see. I didn't feel like this was going to be
simply, well, I didn't think
Yeah.
that we were going to probably make a lot of money taking on the wellness, but I didn't think it was going to be an additional cost to the hospital.
But Charlie, isn't this depend on how you contract with that service?
It's a combination of.
Because you get a global fee per month per patient, you get a set fee. If you decide to do that, if you decide to bill them each month, then that's a different one. What you're saying, or what I hear Cheryl saying, is that, okay, there's 1,500 patients in our CCO that we've contracted to supply these services. We get paid a capitated fee every month to care for them, and that's it. They can be seen one time, they can be seen hundreds of times in a month. We're only gonna get that fee. Is that correct? Because that's what I think they are
So
understanding.
there's two different issues with it. Number one, this is a capitated program, so you're right, there's a fixed dollar amount. The second part about it is because it is a clinic of the hospital, and we are cost-based reimbursed for Medicaid, like we are for Medicare, we won't make money, we won't lose money. And that's really, as we expect, we know that mental health services in Lake County have been very poorly, there hasn't been adequate amount. They're good therapists, just not enough therapists. And by having them part of the district and getting cost-based reimbursement in addition to the capitation, that allows us to deliver more service to residents of our community and not lose money. And that's really the principle why we're doing this. We have the fund balance to help boost us, but we will be able to, through the cost report, recoup any losses that we
They did tell us at the time that there's some other contracts that we could apply for.
And there are. And there are other services that we can expand to that will help. But they're not in the, it's not in the business of making money. It's delivering more service at cost. So, for example, when we look at how many residents of Lake County go out of county, go to Baker City or go to Hefner or go to Klamath for residential care, go to their children or their adults, that were delivered here. It's not that we're going to make a lot of money, we just deliver more of that service in our community and at a cost basis. Great. And that's really what we're trying to do, is improve the quality of service delivered. And then our goal, my goal, is that while it hasn't yet greatly improved services for your patients, and it will, and that's my goal. I hope it will.
Well, I think that's our hope too. I mean, but that's how they pay you. That's why I think adding more services, unless you're gonna add more money, it's just gonna meet your demand. It's gonna meet what you're told you're doing.
Okay, Cheryl, go ahead.
All right. The next thing before we go on to Goose Lake is orthopedic equipment and telephone system upgrade.
So, we sent out to you, I believe you got information about the software upgrade for the telephone system. Everybody get one?
Yes, that's it.
That was it's a software upgrade, so it's not exactly a hardware upgrade, but we did not budget for that. That will provide some improvements. Our overall system, it will allow for queuing, it'll allow for, and we need to have this. So I recommend that we, even though it wasn't budgeted for.
What was the dollar amount?
It's about $22,000.
Does this include the clinics?
Yes, it does impact the clinics. And that's one of the principal advantages, because it's all in one telephone system. The switch is all one system. So if you add it in one, it goes throughout. And it will impact and improve and provide the service that we're not getting in the clinic. So when you call up, the call hunting doesn't work as well by the software. That will be impacted. Remember the other impacts on the telephone system?
Did we get a list?
You're gonna have to go through.
Sure, and that's all right.
So one of the things that we've had a constant complaint about is when you call the clinic, it's hard to get through and to get to the right person. And So this will not make it perfect, but it will improve it. That's our expectation. So I recommend that. In terms of the orthopedic equipment, I sent you a list of a breakdown of some of the orthopedic equipment that we would need to get in order to provide the service here. I have a breakdown of all of the list of all the detail on that if you want to see that.
You mentioned last time that you may also have a sterilizer cost.
True. As we look at the sterilizers that we have, we would need to have one of the sterilizers replaced because it is not large enough. So we're getting quotes on that. I don't have all the specifics. We also have to have, as part of our central supply, right now, when after a surgical case, when we clean the instruments and then put them in an instrument cleaner, and that we would need a larger unit to accommodate that. One of the things that it would do is it would allow for instruments to be put in on the dirty side, and after they've gone through the washing process, opened in a clean environment, that they would be then packed and, Teresa, explain if I have this wrong, and then opened in the sterile room for preparation for sterilization.
Well, but then they go through the sterile, there's another step, but then they're wrapped and go in and utilize, yes.
Okay.
There's the
So that would
washing step and
improve
the
the-
sterilizing step.
It would improve the process that we currently have, but the current instrument washer that we have is not adequate.
And you don't have a ballpark price on
I don't have the exact number on that. And there would be some modification to the space. This would be a bigger, you'd have to put it halfway through the wall, so there'd be some modifications.
that. So did you want us to make a
What's the
motion or
what's the
anything?
amount of that?
I beg your pardon?
What was the amount that they're looking
For
at? What are,
the instruments, it's,
what are you proposing, an amount?
for the instruments, about $140,000, including the table.
Does that
And
include the computer-assisted device?
It does not.
With alignment?
It does not. I have not looked at that, so I can't tell you exactly what that price is.
And that doesn't include any of the parts, pieces
For the patient?
for the patient?
No.
Do those come
This
in
is
on
the
consignment?
instruments.
Yeah.
And then you just pick them off the wall and you buy whichever one you like? It's kind of a la carte?
Well, I
Yeah.
know the
There's a
wrap
lot of
up.
that.
I think that there's a determination of what you need prior to a surgery, but.
This one
Well,
looks
I
like
mean,
it will fit.
my hip's, my hip's different than your hip, and your knee is different than Chuck's knee. I mean,
Right.
it's not one size fits all.
There's
So
a
either
wrap.
you have to invest in a whole bunch, or the.
No.
No, you
The wrap.
don't, you actually
The wrap
don't
comes.
invest in those. They're made available by the vendor on consignment. And then they have a variety of different types and sizes. And then you only use what is needed. So you're not actually purchasing those items until you actually use it. So,
But
it's
you
not,
ultimately have to purchase some. If you think you're gonna do fracture care, you've gotta have, you
Right.
have to have a set of hips, bipolars, whatever.
there will be some of that.
So, I mean.
I'm really losing.
Isn't that true?
Yes,
Sorry?
You're gonna have to purchase some.
we got Dr. Graham, he's soft spoken. Girls and boys,
Yeah.
speak up.
Teresa, could you speak up a little
Speak
louder?
up.
So that,
She can't hear.
Okay.
Jane.
So, in looking at this, what I know so far is that we've looked at instruments for both the joint replacements as well as the fracture care, the trauma type patient. So we're looking at those instruments, and there's a variety of those for different situations. And then we're also looking, we have the company that she likes, we're working with that company, that's the company rep that would be present if there were a joint replacement. And then we're also working with those reps to sort of hone down exactly what we want on which trays, and to look at what particular things we have to do to match up with our current instruments and our current drills. So that whole process, this whole analysis is sort of in process. And we're actually looking at doing a couple days of our team in a cadaver lab, so that the team not only practices, but also makes decisions about which instruments and how many of each go in the different trays. So that's all projected to happen over the course of the next month. I don't know if I answered all of your questions.
Well, I guess I
Brad.
don't know what's on that, but you just pretty much, that's a skeleton. That 148,000 is really,
It's kind of it's kind of a general
it's not even
number,
gonna
right?
touch the surface is what's gonna happen. This is gonna be a $500,000 to $1 million venture. With the computer
there's-
assisted devices and all this stuff. I mean, this isn't gonna be a $148,000 venture. You can't say yes.
Well, I only know what I've seen so far. I know what the washer and the sterilizer estimates are, I know what the instrument estimates are, I know what the table estimate is, I know that there's an effect in radiology. I know what the general effects are. I don't know of any other things yet.
Well, I know I sat here and listened to her say that she needed a computer assisted device to align her needs appropriately. So I don't know what that's gonna entail.
I think that what she said was, and I don't mean to disagree, but what she said was that they did buy a system in McCall after several years, and that might be something that we look at down the road if we have a certain bond.
She hasn't proposed that to me.
She has not proposed any.
Well, I mean, I remember her sitting there saying that it's a great tool, and I just know we practice medicine based on standard of care, and I'm held to the same standard of care as an ER doc in a manual hospital, and, you know, if you're gonna meet standard of care and you're gonna compete with the big boys, you've gotta have the equipment to compete with the big boys. And that's all I guess I'm just implying is that. I don't know what that figure has entailed, but she sat here and said it's gonna be a $500,000 plus venture up to $1 million. Well, you were here. You probably heard that number.
I heard the big number on what you wanted, but I also heard about $250,000.
And my understanding was she was not gonna have to have a computer assisted device. And I really doubt that most of the ones we work with do have that. So I don't think they use that on mine in the past.
Most of them do. Okay, all right.
Shall we move on?
Let's do a motion to approve those. They're just on there for information.
The telephone system upgrade, because it's a software, it's not a capital, well, it is a capital purchase, but it's not, it is an equipment purchase. That was not listed on our budget, approved budget, so I would like that approved. We did put money in for, for additional instruments, but not the full amount that we're looking at on. So, if you,
Charlie, could we approve the system software upgrade and table the other? Would that meet
we can do that.
the criteria that would work for you to move forward?
Well, we probably need to, if we're
At
gonna
some
do
point,
it.
for sure, but it sounds like we've talked anywhere from 140 to $1 million, so I think we need, at least I would like some type of
And I
certification
agree with
on
Carol.
orthopedic equipment, so I guess.
Well,
Chuck, I would
we
just
are
so
gonna have a
move-
meeting on the work session on the 10th, and we could actually bring the subject up then.
Get more accurate
Right.
information. So I guess, Chuck, if you'd like, I would so move that we would approve the software upgrade amount and cable orthopedic equipment amount
Of about 22,000.
of about 22,000.
Is that right?
I will second that motion.
Moved and seconded, those in favor?
Aye.
Aye. Did I hear you, Jan?
Yes.
Thank you. All right, we'll move on.
Okay, Lakeview Gardens. Patient counts were at 664, which was up from October. Another very good month for Lakeview Gardens. It's all because of Larry. Okay. Revenue for the month was $190,000, which is this bar right here. Our monthly average this year is 195,000, so 190 is not bad, it's a pretty good month. Their profit and loss for the month, contract labor, so here is our loss of $23,000 for the month, and look at contract labor was $36,000 for the month, so worker shortages is a hard thing for us to deal with.
Is that mostly CNAs or what?
It's all
Yeah, they're all
CNAs.
CNAs. We just hired 3 new ones though.
And
we
we're
have,
training some here pretty quick.
yeah, we have a new class starting the 3rd of February.
So year to date, we have a gain of 40,000, which is a whole lot better than where we were last year at this time with a loss of 109,000. So really, that's a pretty good month. The balance sheet for Lakeview Gardens, I really don't have really nothing changed. They continue to pay down their debt to the hospital, generate cash. Moving on to Goose Lake Medical Services, we have kind of lost Dr. Gilbertson. She's on medical leave. Our revenue for the month was $36,000, which is terrible, bad month. We do have Dr. Lee going down now. And, you know, because I like to look for a bright note, he did see more patients in one day than Dr. Gilbertson was often seen a week. So I don't think we're going to see a big impact in December because he wasn't there much, but I do think that by the time we start looking at January, we're going to see more visits with Dr. Lee down there.
And Cheryl, Gilbertson's scheduled to be back on Monday the 9th. So she's supposed to be back.
Oh, good, I didn't know that. Okay. The loss for the month for Goose Lake Medical was $26,000. Their loss for the year is now at $32,000. Last year we had $24,000. Had about the same place. Balance sheet, I really don't have much to say. No changes there. Okay, and then I do have. I didn't send these to you guys yet, so I'm sorry, but I will send them out to you so that you can study them a little bit. I can just barely get them done. So this is the month of November for our DME business, our wellness center, our medical supply business. Year to date, we have a loss of $38,000. We had budgeted for a loss of $30,000. So we have a little bit worse of a loss than what we anticipated, but still I think we're pretty close. And you see on the balance sheet, I think we talked about this at the finance meeting, they do have debt to the district of $152,000.
That's in his inventory.
Yeah.
And to answer your
Well, as
question,
long
that
as-
inventory came out spot on.
Did it?
Mhm. Yeah, it's kind of his inventory and his loss to date, really. And I did talk to Michael today, and he was telling me that, so we did just get Medicare licensure. And so now we can start selling oxygen, and we have actually been selling oxygen at a pretty good clip. So right now, monthly billing or profit on oxygen is gonna be $750, and based on projections, what we see as coming sales, we think that number is gonna be up to $3,500 a month in the next few months. So I do think that being able to sell oxygen to Medicare patients is gonna hugely impact our financial statements here.
Has he been able to talk with Lincare into letting us service somewhere?
I don't think that Lincare at this point is interested in giving away all their business to us. But our service honestly we've picked up several Lincare patients already because the service is just really good and it's in town and Michael is very enthusiastic about it. So we've already picked up some. So.
Can I back up a minute, Charlie, and ask a question about Moose Lake? While we continue to see a loss down there, are we continuing also to see hospital revenue from there? What is that? What are we seeing kind of on a monthly basis for that? We just cannot seem to get that, clinic turned around. Maybe there's some hope now with Dr. Lee down there, with some other changes, but.
Our auditors, we talked with them, I think you've heard us talk about changing the license to be near the district. And we just got a day or two ago a list of the items that they need to have to get that completed. And they're fairly confident they'll be able to have that changed to be in the district in the next 3 to 6 months. So that was significant.
But what approximately are we seeing in hospital for revenue?
Like
Out of Alturas, out of, how much?
It's $2.5 million a year.
A year?
Yeah, $200,000. And it's kind of just leveled off.
Is that just from ancillary services?
I don't know what it's from. I just really look at it from a zip code basis. Code could be any number. Yeah.
Could be ER visit?
I mean, we could, yes, ER visits and ancillaries. There probably is a lot of lab radiology, but, yeah,
We could get the breakdown, we just haven't done that in a while.
yeah.
But we can get that for next board meeting.
Mhm. Yeah.
Is there still that searching coming up from Susan Bell? Because Eric was going down there helping out colonoscopies and some surgery stuff. Is that still happening?
It's on a periodic basis.
It's not ready.
And they also had a surgeon that was coming out of Fall River Mills, and he has indicated he's not going to continue doing that anymore. So those are,
Cheryl, do you have
I'm done. I'll get it.
medical staff privileging? Leader sent a rather extensive list of staff privileges.
Yes, trust me, the medical staff got to look at it last month and they were like, wow.
I saw one name on there, Mr. Gallagher. I'm not sure that we want to remove him.
That's my neighbor now.
it is much as Dr. Gallagher's not here today. I could ask Dr. Graham, who's a representative of the medical staff, but Dr. Gallagher being the chief of staff, who obviously was tied up in the emergency room or otherwise unable to be here. On his behalf, the medical staff voted to approve and recommend to you these renewals that we sent out to you and the new appointments. So we would recommend, on behalf of Dr. Gallagher, recommend that you approve these renewals and new appointments.
So moved. So seconded.
Moved and seconded to approve the medical staff privileging requests. Those in favor?
Aye.
Aye. Thank you.
Thank you.
I think he signed his own approval.
Geothermal letter from the town.
Did everybody get a copy of the letter that was sent by?
We did, and there's some issues there, Charlie, that I would like to discuss in our executive session.
Perfect. Make that.
So we're putting this into executive.
into executive session because it's a contract agreement. Has to do with contracts.
Sorry to put that on there.
That's fine. Employee recognition.
We've had lots of great employees doing lots of great things. And in the month of December, as I look at all of the hard work that many, many people did, probably the one that put in a great deal of work to make the employee Christmas party the most success was my assistant Jen Ant.
Oh.
And Jen is our employee.
I have to,
Thank
I
you.
thought would agree with that.
We all agree with each other.
Where's the stringer?
She saved the day, let me tell you.
CEO report.
Okay, we have a couple things. Teresa, did you want to say anything about the falls issue?
Oh, yeah.
Oh, I'm sorry.
It's good.
Yeah. So, so every year we have like a fall, you know, we try to lessen our falls for patients. And it's falls per, I don't know, 1,000 patient days or something. It's not the actual number of falls in a year, but we started out with a goal to be under 7. And we started out early on this year with really difficult patients, and we had a number of falls, and so we thought there was no possible way we were going to make it. But we did end the year at 5. So we actually made a vast improvement. So next year, our goal, of course, is to keep it at 5. And we've done several different things. We've gotten more devices to help with that, as well as our enclosure bed that we use for impulsive patients, that we just absolutely compulsive confused patients that we have difficulty keeping from hurting themselves. So
What is the restraint on
What is-
compulsion bed?
it's a bed. It's like kind of being in a tent. It's a netting. It's made out of netting, and it keeps
Teresa,
them.
I'm sorry, I can barely hear you.
I'm sorry. My voice doesn't carry very well, Jane, sorry.
Okay.
So I don't know what part you heard, but I was saying that we have improved our falls rate and.
Oh, falls, okay.
For patient falls, and that our rate has come down significantly in this calendar year. So our target for this year, I didn't bring the numbers, I'm sorry, but our target for this year was to get under 7, and we actually made 5. So, so we did better than expected, and quite a bit better than last year, which was 9. So, so that was I was just saying the team did extremely well this year.
Teresa, does that include long-term care, or is that just acute?
No, this is acute.
We track long-term care also, and we try to do all we can to prevent falls from occurring. And we have different mechanisms for doing that. But I thought it was significant that we made such an improvement for acute. So that was important. So some of the other, Teresa, did you have anything else from a nursing standpoint you wanted to say?
Probably not. I think you're probably gonna are you gonna cover the swing bed changes?
Okay. So January 9th is when we anticipate our new CT scanner. It gets through the I-5 highway and over the pass. It is in, the new Siemens CT scanner is in Portland, and it's scheduled to be here, provided the weather holds up. So that's pretty exciting. We have, you've seen out front, there's a temporary unit where the temporary MRI, or the mobile MRI was. And that's because we have disconnected the old CT scanner. We've done all the electrical work, so we're prepared. And then the training will go on. And the training, as I think you may have heard, will occur while we have one of the interventional radiologists here, so that we get training with the Siemens personnel and very busy days. So that'll be really exciting.
A nice little informational ad in the paper tonight on the transition from the scanner. Whoever does that for the hospital is a nice ad.
Is that Jimmy did that?
Was that
Oh,
you, Jen?
no, that was
Jen
me.
did, Jen did
Jen
that.
did that.
I did that one. Yes,
Yeah.
Tyler
Yeah.
put that
Month.
together, so, yeah.
Sorry, I didn't see it.
You might
Thank
get
you,
the award next month, too.
Tara Guile, today was her last day working here, and she's now going for a 6 or 7 month clinical internship to become a dietitian. She'll be at Carson Tahoe, and we made arrangements for when she's gone, when she gets back, all things going on. She passes all of her final issues, she'll become a dietitian. So that's really pretty exciting to have her gone through this process. We're excited about that. We've engaged a software company, Arcadia, it's called. I think I've talked a little bit about it, but Arcadia software is, as part of the CCO, they're contracting with Arcadia to provide for both our clinical work as well as our mental health work, and trying to do data analytics on the patients that are being seen, and to assist in identifying patient needs that might have not been, patient have not come in for something. So helping to improve the service that we're doing overall. So that is in process right now. It'll take about 3 months to get all the connections done correctly. So we're looking forward to that. We hired a new licensed professional clinician. Her name is Heidi Martinez. She will be working in the wellness center, and she will be our clinical supervisor, so reviewing our clinicians and able to see more patients. She comes to us from Colorado, but has spent much of her career in Clement Falls. So that will be a good addition to our community. And she's worked with Trace once or quite a bit. So that's a good addition for us. As Larry said, we are now advertising for our next CNA training class that will start in February, the first part of February. So we'll be interviewing people and making selections at the end of the month. So we're excited about that. And as you can see, it impacts us directly if we don't have CNAs. The Alevent training, our Alevent program, this is the funded program by the Oregon legislature. Alevent is the company owned by Mayo Clinic and is part of the swing bed program. The kickoff starts, I believe it is, first calls are next week, and then they'll be progressing. So we will be participating in that. This is to expand our ability to take on swing bed patients. So we'll see how that works. I don't know how many hospitals in the state of Oregon are participating yet. We'll find out a little bit more. I think that there's maybe a dozen that are going to participate, maybe more. Because it was offered to all of the rural critical access hospitals in the state of Oregon. January 23, CPSI is going to be upgrading software as well as some of our hardware. One of the things that has occurred since we bought the CPSI system, we have not had a complete upgrade of the hardware. And as an example, our backup tapes are no longer supported, so we have to replace them. And if you're replacing the tapes, you have to replace some of the servers and some of the components that go with it. So this is the process that we had budgeted for this, and we're going through that. There will be some downtime for the hospital. Hopefully we can schedule it, and they're working on making that happen. As Teresa said, it has been a very busy time the last, well, since the 1st of January. We hit, I believe, all-time record, 21 patients in the hospital. So kudos to all the nurses and of course to our doctors who were taking care of those patients. We have a new PT student. He's on his clinical rotation, Art Heiser, who starts, I believe it is Monday, and he'll be with us for about 3 months. He trained at, I believe, one of the same facilities as Amron did, and this is a part of a clinical rotation process, and we like him and he likes us. That'll add to our list of practitioners that we have here. And as we continue to grow in our rehab department, we believe that we're delivering really competent services and we are able to handle stroke patients as well as other kinds of rehab. You have any questions of me? Other than that, that concludes my comments.
We will take a 10-minute recess, come back, and go into executive session, under ORS 192-650, grade 2 H, C, and H.